Health and Homelessness in the School of Dentistry. I'm David Ludwig. I'm the coordinator for the course. Thank you all for coming. What disciplines do we have here? Raise your hand if you're in dentistry. Okay, so the first year class is here partially for the cultural competency class that Dr. Grenadier is coming. What about school medicine? You? Nursing? Any nursing? No nursing this year. Social work? Pharmacy? Anyone else? So semi-disciplinary. But thank you for coming regardless. If you have any questions throughout the quarter, just feel free to talk to me if you see me before or after class, or feel free to email me. So usually I start the quarter by talking about homelessness in general for the students who haven't taken health and homelessness before. It's actually perfect timing. I talked about the one-night count, which is the counting of all homeless individuals.
Thanks, sorry. Just need to get past here. No problem.
Even on one of the coldest nights of the year, you still can't find housing. Last year, there were 2,700 people, men, women, and children, that didn't have shelter on January of last year. And I actually participated in that. That's a picture from last year. And then another 6,000 are in shelters or transitional housing or sleeping on someone's couch surfing. So there's a great need for services for homeless individuals. It's a big issue, and it's increasing, a 2% increase when comparing over the year before, and 5% increase when comparing the total number of homeless individuals in King County. So this year's event is Friday, January 24th, and it's at 2 a.m., so that's Friday morning. And you go, I'm leading a team if you're interested in joining that. We go to like a predetermined area of the city. My group is in U District, and we count people who are in their cars, sleeping under bridges and overpasses. So it's quite an experience to be able to do that and see, you don't just kind of picture people under the bridges, you're actually counting these people as human beings. I also used to give a quote by Christine Cunningham. She's a executive director at Roots Young Adult Shelter, which we volunteer with. She's a community partner of ours, and she told me that dental care is one of your most requested services, but once she learned about how interdisciplinary this course is, she came to the realization that it's not just dental care that's needed by the homeless populations, it's healthcare in general and a collaborative effort between all healthcare providers. So the objectives of the course, we hope in these next 4 sessions after today to talk about the social, cultural, legal, political factors that lead to homelessness in Seattle, understanding what challenges people find or people come across in finding shelter, what are the oral and systemic health issues we've had. Even though this class is hosted by the School of Dentistry and the Department of Oral Medicine, we have speakers from all different disciplines. So don't be scared that if you're from a different discipline, it'll all be about. Understand healthcare access problems for the homeless. And then the real important part is the hands-on experience. So the required part of the course is 6 hours of community outreach. And I'll talk about that in a little bit. But the idea is that what you see in the class here, when I hear from Dr. Danielson and other speakers, can be reinforced in what you hear in class. You'll see, hopefully, as part of those experiences. And that's kind of what I was just talking about. So, we bring in experts from the field. We hear from people from different shelters, from different clinics around the community, and then we kind of use that knowledge when we're out at Roots or we're out at the Union Gospel Mission or the 45th Street Clinic. So the requirements, there are 5 lunchtime discussion sessions. They're usually on Thursdays. Today, it's the only one Wednesday section. And we have all of them booked up except for one, and then the outreach requirement, as I discussed, which is 6 hours per quarter. The schedule for this quarter, I'll go through this really quickly. We'll start today with Dr. Danielson to talk about social determinants of health. In a few weeks, we'll hear from Nancy Amade as the legislative session picks up. There are a lot of advocacy days, and I'll send out another reminder about those. So in your respective department, if you want to participate in their lobby day, I'll have information on that, and then she can help prep us of how, if you want to talk about homeless issues at one of those lobby days. I know probably 100% of the first-year students are going to dental action day, but I don't know about the other students. Then we'll go have Caleb Banter-Green, who I've heard before from the UW Alcohol and Drug Institute, talk about drug abuse, addiction, and homelessness, and he's an awesome speaker that will start in February. Our last scheduled speaker for the quarter is Maggie Green, who a student in the class last quarter recommended as a speaker. So if you have any recommendations, if you're working with a community partner, feel free to give me suggestions on who to bring, or if you'd like to hear about a specific topic. She'll talk about families experiencing homelessness. So some of the community partners that we work with are 45th Street Clinic. That's an ongoing project in the School of Dentistry that was started by a dental student years ago. The Union Gospel Mission in Pioneer Square is a new program working with their dental clinic, and it's one of the strongest at the moment. There are, I think, 12 days this quarter just the Union Gospel Mission. Medical Teams International, we work with the mobile dental vans to provide dental care for homeless populations. The Downtown Emergency Service Center is part of the Community Health SHAP, I guess I don't know what it stands for, group, and they do foot care at the DESC. And they also work with us on teeth and toes, so that's a collaboration between medicine and dentistry. You might have all heard about that yesterday at the service kickoff. But upcoming events, we do have a teeth and toes foot care training. If you're interested in going, which is I think tomorrow evening at 5:30 in the T-Wing. If you're interested, I think I sent out an email about that, but you can contact Takashi or sign up on that Join site. There's also a teeth and toes event at Roots where we'll do foot care, and then oral health care. We got an affiliation agreement with the Roots shelter so we can apply varnish and do exams and look more in depth and make referrals. Another opportunity is the U-District Conversation on Homelessness, which is usually the first or second Monday. Actually, that's the wrong date. Sorry. Oh, the date's over there. Okay, Monday, January 13th. And the topic is kind of preparing us for those lobby days that I mentioned earlier. What about emergency shelter in the U-District? How shall we advocate for housing in the 2014 legislative session? You may have signed in at the front. If you haven't, do so before you leave. And then there are also speaker evaluations that can kind of help guide Dr. Danielson in the future. So before I hand off the mic to him, just want to tell you who else plays a role in this course. Dr. Dara is the faculty sponsor for the course. Her and I came up with the idea for the course about a year and a half ago. Student leaders, Keegan, whereas he's a second-year dental student. Anna, is she here? Not today. And then myself, and then Awasek provides a lot of the support for the course. Got the food, gets the room, coordinates the lodging, so it's really valuable. So if you have any questions, the website is tinyurl.com/health and homelessness. And you can email me at dlud@uw.edu. So why don't I pass on the mic to Dr. Ben Danielson from Odessa Brown Children's Clinic. He's the medical director, and we're happy to have him.
Thanks very much. I really appreciate the chance to come and spend a little bit of time with you talking about one of my favorite topics, which is the Odessa Brown Children's Clinic in the heart of the central area. Clinic's been there for 44 years. It's an amazing place, and I know some of you some of the time get a chance to visit there, see our dental program as well as the medical clinic and our mental health program. It's pretty amazing. It's a real privilege to be able to work with the families that we serve there. And I wanted to spend a little bit of time today talking about some of the connections between the conditions that the families and the kids that we serve live in, and some of the ways that we try to address healthcare issues and other unmet needs in the clinic. I know I'm on a little bit of a time crunch, so I'm going to try to move it along, but please, if you have a question or comment or something doesn't make sense, also please stop me and ask me, and I want to hear from you. Okay? It's really, really a privilege to be here. I love coming to the school to share time with you guys. So the Odessa Brown Clinic is right there. The video that was being played earlier showed some scenes from the summer health fair, which dental students were really the leaders in running and organizing over the past couple of years. And it's really great to see such involvement from many of you in getting some face-to-face connection playing with kids. This slide also just wanted to emphasize the power of women. especially in community endeavors. It's just an amazing thing. And you'll notice if you go to different community events and community locations, they're almost always named after women, which puts a real shame to my Y chromosome, but it also makes me recognize just how strong and how amazing. Some of the women, like Odessa Brown in the lower center there, and Blanche Levizo, who was the first medical director for the clinic, Maxine Hayes, who was in my spot for several years and is now the state health officer for the state of Washington, Liz Thomas, who was the first, the far right, was the first nurse practitioner, African-American heritage, who graduated from the nurse practitioner program here at the U and devoted her life to serving the community. Strong women carrying the water for communities. That's the thing that I hear about and see and learn about over and over again. The slide didn't come out perfectly in the translation. This is just a map of sort of Seattle and South Seattle and parts of South King County with an overlay of colors where blues and darker blues and greens are areas of higher poverty. And normally the slide is just be speckled with many little red or black spots all over, showing where 5 or more families come from that go to our clinic. And the point is, a lot of families come from South King County, and all of the areas where we have families coming to our clinic overlap with the areas of higher poverty for Seattle and South King County. And also, no families come to our clinic from Mercer Island. I'm recruiting, but we don't have any. We serve mostly Medicaid eligible families. Almost half are African American. Almost 1 in 5 speak Spanish exclusively. A lot of East African, Eritrean, Ethiopian, Somali, or Oromo families come there. And a lot of the county's foster kids get different forms of medical, mental health, and dental care at the Odessa Brown Clinic. When you talk to or listen to the parents and caregivers who are taking care of kids who come to our clinic, you start to learn a little bit about what their lives are like and what they deal with. I am always reminded by the wisdom of this grandmother who said, both of my kids, grandkids, high blood pressure. These are kids who are 10 and 12 years old. And this shocked me when I finished medical school and I went into pediatrics and found that I was suddenly treating primary hypertension in such young people. And I wanted to start to understand why. And it's wise people like this grandmother who sort of knew the answer to that question. When we spend time talking to families and asking them what keeps them up at night, what are the issues that they deal with every day, we hear things like this from a survey a couple of years ago in our waiting room, what kinds of issues families deal with. Caring for older family members, having to try to find child care when a child with special needs is really hard. We have one of the highest rates of medically complex kids coming to our clinic out of any other primary care clinic in the area. Having issues with finances, having a family member who's been in the legal system and being able to try to find housing and things like that are real challenges for families. Fear of immigration, officials being threatened and bullied at schools and having drugs and other crimes happening around them are things that they face every day, and it's humbling to me when I get on my high horse and say, you haven't taken your asthma medication today, and to think a little bit more deeply about what are the many other kinds of big challenges and concerns parents are sometimes bringing with them when they walk through the door. We have a really amazing mental health team who provide a lot of services, and one of them is really focused on moving upstream and looking at early interventions to help kids stay healthy from a mental health standpoint rather than fall into some of the challenges that come with behavioral problems. This is just a snapshot of some of the kinds of risk profiles that these kids under age 5 already face. They've already been exposed to things like sexual abuse and abuse by peers, have significant behavior issues starting to well up, developmental delays or physical abuse, and of course, none of these kids just has one of these, right? These kids are dealing with some combination of multiple behavioral and unfortunate exposures already in their lives before they reach the age of 5. And when we look at their families, I'm sorry for this long list, but I'll just mention a couple of them. These are the kinds of things that parents and their caregivers face, and these are the environmental things that these kids are facing at home. 3/4 of these families have biological parents who have substance abuse struggles. Most of the parents have mental health issues. Most of the parents have faced neglect in their childhood. Lots of family discord, lots of alcohol use and things like that, troubled siblings, teen parenting, those kinds of challenges. The context of living for a lot of these kids is really different. It's really challenging sometimes. And it comes from a lot of the environmental things that they see in their world. If you look at just the raw data across the board, you'll see these many reports over the past 15 years, including Institute of Medicine report called Unequal back in 11 years now. It really pulls together a lot of the data about healthcare inequities and differences in health outcomes for different populations. And this is no surprise to any of the families I work with in my clinic. They know that the rates of just about any condition are higher by 2 to 3-fold and are more severe most of the time for the families that come into the clinic. When we look at data for Washington State, we see the same kinds of things. This is the healthcare authority that oversees Medicaid, and they look at what happens and what are some of the different rates of conditions and challenges that kids on Medicaid face across the state, and they find these differences based on race and ethnicity that are sometimes striking. The low birth rate, for example, for African Americans are 70% higher than for the lowest rates among whites. And C-section rates are higher for African Americans, but very low for American Indians. The rates of getting appropriate immunizations and getting good checkups vary by race across the state. And this is the kind of data that really surprises state officers and state health officials when they try to provide services across the board. It makes you start to think about what are the components of communities, what are the individual characteristics of families, and what are the challenges that make it so hard to deliver appropriate care equally across the system to the families that need them the most. This should be easy. We all work in this field and we all care about helping each other and helping others. It should be so straightforward to be able to find kids who need services, adults who need services, and get them to them. And yet it's extremely complicated. It's extremely difficult. And if I didn't work around such great people every day, it would be a little bit disheartening because sometimes the fight seems like it's pretty challenging. You can look regionally at different areas and at different health concerns, and you'll find that place matters so much. There's a course of videos called Unnatural Causes that I'll bet at least some of you have seen before that really talk about some of the special features of that place, just where you live, how much that affects your health and what kinds of things you might face just based on your zip code or what street you live on. This is just one example. This is the rate of getting good prenatal care, or the opposite of that, getting late or no prenatal care, LNPC, based on where you live. And the darker areas are worse rates, and they concentrate in South King County, the area that our families come from. In fact, if you look by county or by zip code, you can see a lot about different neighborhoods. This is a stupid slide from a few years ago now, but it really strikes me because it was mostly about housing prices. But what one person realized when they looked through different housing prices and average houses, this is pre-Great Recession, they found that the price of a house could tell you about the rate of obesity in a community. The higher the price of a house, the lower the rate of obesity in a neighborhood. That you could be a real estate agent and know a fair amount about epidemiology of health outcomes because place matters so much. Is that weird? Okay. In South King County, the families that we serve most come from that kind of yellow area, South Seattle, downtown Auburn. And in that area, what we see is that kids are twice as likely to drop out of high school as compared to East King County and North Seattle areas. Southeast Seattle residents are 4 times more likely to die of diabetes than are Mercer Island residents. The youth of color in King County are 6 times more likely to spend time in a correctional facility. So the life expectancy in South King County actually is 10 or 11 years less than in other parts of King County. There's a decade difference in life expectancy, and in fact, somebody on Mercer Island could be looking across the water at somebody in Renton and see someone who is going to live 10 years younger, less than they are. And Seattle and King County has this interesting dynamic where Seattle proper is the 5th whitest city in the country. That Seattle and King County has some of the greatest philanthropy, the highest rates of giving and philanthropy in the world. And that zip codes, especially the 98144 and the 98118, which are right here, are the most diverse culturally zip codes in the whole country. We have all of these interesting contrasting and kind of dynamic features of different areas that really make you realize how much place matters in terms of what you see, what you get exposed to, what you learn about or don't learn about, what you experience, and what opportunities you have. Isn't that weird? That's weirder than the house price one. I'll just... And it's interesting to think about Seattle because I think I came to Seattle thinking of it as a place of relative largesse, of relative privilege, of relative high standard of living across the board, and that's not necessarily so true as I would think. You will probably know more about this than I will going through this course, but it's striking to me to think about what happens with family homelessness and what the rates are. And you find that Seattle actually has rates of homelessness that are comparable to most other big cities across the country, and has resources for those families that are also similarly strained to other places across the country. Looking at it a little bit more simply, when you look at rates of homelessness, Seattle gets into the rates of ours that are much higher than most of the other counties around the country, with the exception of areas where you're maybe more likely to expect to see high rates of homelessness, like maybe New Orleans or Tampa or Las Vegas or Fresno. We are right up there with them, and not in a laudable way. If you look at it just with numbers, you find that Seattle kind of sits, Seattle-Tacoma has rates of homelessness in this sort of 38 range that places us around number 8 in the country, and not a good way. The 8th worst rates of homelessness in the country. When you look at the effect of homelessness on different things, you find interesting information. You see what happens with really fuzzy slides, but especially what happens when you break out different racial and ethnic groups. You find that for students in the Seattle area, 1 in 9 American Indian, Alaska Native students are homeless. When we look at the rates of homelessness across different groups, you find just how disproportionately they are represented among different populations. If you look, for instance, at African Americans in Seattle, they represent around half of the homeless kids of school age in King County. These differences around neighborhood and place and race are significant, and they find themselves to be true again and again and again in the different ways you look at this data. So the extent of childhood homelessness in Washington State across the board places it at a rank of number 35. Number 35 out of 50, this time where 50 is the worst. Child well-being score for Washington is around 34th. 50 again being the worst. The rate of child homelessness places us right in the middle, and our overall rank places us right smack in the middle for the country. This is striking to me, because again, I think of Seattle as a progressive state, as a city that's progressive, in a state that has a fair amount of resource, and that has been at the forefront about trying to solve health and healthcare problems and improve quality of life for the people that live here. And, you know, we sit pretty much kind of at a C plus when you look at us compared to other states. You'll learn much more about this, but just quickly, what does it makes for homelessness in communities like Seattle and King County? And a big chunk of it is job loss. Another big piece are bills, like medical bills. Another big piece is family member discord, where there's eviction or abuse at home, family members who are incarcerated, sick and disabled, especially mental health diseases and conditions, and then changes in family status like divorce, and the scourge of drug and alcohol problems. And most families have 2 or 3 or 4 or 5 of these factors all adding up to create homelessness and housing insecurity for them. We've seen different rates of things like unemployment across our county, just like we have across the country over the past decade or so, and it's been very interesting to ride this wave that has been the Great Recession, which starts around 2008, and then has led to such high unemployment rates, even in Seattle, that has been relatively protected from those high unemployment rates around the country. Got climbing way up into the 9.5% range before starting to improve now over the past year or so. Super cartoon. You have to tell us again the story of what life was like before 2008. Unemployment does not affect different communities equally. If you live in South King County or Southeast King County, the rates of unemployment are significantly higher across the board than in other places. So when you hear statistics about Seattle and King County having low unemployment rates in the 4 or 5 or 6% range, that's seeing Seattle proper with an unemployment rate that's maybe 3%. and other areas in South King County that are less populated, the efforts of 8 or 9 or 10%. If you look at unemployment and poverty by different racial and ethnic groups, what you would hope to see over the past 10 years or so is that those rates are improving for each minority group, but that's not the case. If you look at King County here, for a lot of the populations that have suffered the worst health disparities and worst health outcomes, things are not on any trend towards improvement for them. The Native Hawaiian Pacific Islander population in 1999 went from a rate of 16% of poverty, living in poverty, to a rate in 2010 of 38% of Native Hawaiian Pacific Islanders in King County living in poverty. We're moving in the wrong direction. We're moving in the wrong direction in this state and in this county, just as we're moving in the wrong direction in terms of increasing poverty for the have-nots across this country. And when we look at the distribution of kinds of supports and resources that are hopefully going to help change those trends generationally, you don't always see the things you want to see. Here's just one quick example. This is the percent of kids who are in Head Start or ECAP. Everybody know what ECAP or Head Start is? Early learning, early educational opportunities for young kids before they start school so that they can enter school ready to learn and thrive. So they can enter school with the ability to learn, as well as any kid who's coming from a higher resourced environment or a more privileged family. Head Start and ECAP programs are really important. And you can see the distribution of where Head Start and ECAP programs are for different families in different neighborhoods. The purple bars are neighborhoods in South King County, and the distribution of Head Start and ECAP programs there are significantly lower than Seattle in general, around 18 to 25%, which is unfortunate because when you look at the ultimate measure of how those Head Start programs work, what you're looking at is high school graduation rates. And the lowest graduation rates in King County are occurring in Tukwila and Highline and Federal Way, parts of South King County, where the rates are as low as 60%. 60% dropping out of high school in the last 2 years ago, school year. These rates are really different, and the resources that should be supplied to the families that really need to help get a leg up to improve their status is really not distributed equally. Free and reduced lunch meals, on the other hand, go much more into South King County than into other areas, which is just a way to see just how much the families that come from those areas are both feeding insecure in addition to housing insecure. We have in King County, just like in other major metropolitan counties, great areas of food deserts. You've probably heard this term too, right? Food deserts, areas where it's really hard to find adequate, nutritional, and affordable foods for families that you serve. And for us in South King County and South Seattle, the food deserts are kind of large areas that really overlap a lot of the areas where kids already face the highest rates of poverty and disenfranchisement.
Is that in terms of access to grocery stores, or?
Yeah, that's an aggregate measure by the U.S. Department of Agriculture, where they do this little map thing that helps them identify food deserts with distance to travel, affordability, and quality of food are kind of mashed together. Food insecurity is a major problem. It spans many geographies and many socioeconomic circumstances. 40% of the people on Food Lifeline choose between paying for food and paying for rent or mortgage. Almost half of the Food Lifeline recipients have to choose between paying for heat or utilities or paying for food. A third of the Food Lifeline recipients are children. The rate of foreclosures and thereby the process of leading to homelessness is also distributed in a way that's in higher concentrations in South King County, and 1 out of 4 people who experience homelessness in King County are children. Housing insecurity, not just being homeless, but also being unsure if you have a temporary home where you're going to sleep the next night or the night after that. Housing insecurity has a definable effect on people's health. For kids, it increases the risk of being hospitalized by 30% by the time a child is 3 years old. It means fewer dental visits, 10 times the rate of caries, disruptions in friendships, and it interferes with the child's ability to stay in school. 20% miss 3 weeks every 3 months and are in more special ed and are behind 1 grade for every 6 years that they're in school if they face housing insecurity. These effects are significant, and they're even more significant when there are children with special health care needs in those families. Families who have kids with special needs have rates of homelessness that are higher than other families, even if they're in the same income brackets. So the families that we serve in King County, 60% of the kids are housing insecure or homeless, and that means they're surfing on a couch. The family distributes them to some other family members part of the week. In the summertime, they may sleep in a car. In the wintertime, they may move around from one place to another. 3 times more likely to have food insecurity, and even the basic needs like getting a $50 loan or getting a ride to the doctor or something like that are challenges that they face in disproportionate ways. And that issue is part of this bigger issue about wealth and income gaps. I'm going to stand on a soapbox for a moment and talk about that. This was an interesting study to me that was done in Harvard Business School a few years ago. It asked these 3 questions. What is the actual distribution of wealth in this country between the top 20%, the next 20%, and so on? They asked people in surveys what they think it is. This is what they thought that the income distribution really was across the board currently. Then they asked people what they really felt like it should be. And this is what respondents said in terms of what they felt like income distribution should be. It tells you 2 things really clearly right away. We think right now that the wealth distribution is not the way it should be in this country. And we actually are wrong about what the wealth distribution is. It's much worse, in my mind, than we even think it is. This is also striking to me. If you took all of the wealth in this country and divided it up as if it were property or land mass, this is what would happen. 40% of the U.S. population would live on that $1. 40% of the U.S. population would own the equivalent of, I'm going to go out on a limb and say Laredo, Texas, but I don't really know where that is, would now own that one little dot. The top 1% would own that wedge. The next 9% would own that. So 10% of the wealthiest would own that much of the wealth in this country. That wealth gap is increasing steadily, and it's continued to increase for 100 years now. There's a group of epidemiologists in the UK who did a book a few years ago called The Spirit Level. They talked about these wealth gaps and how that affects health. And they studied around the world what happens when you compare health outcomes or well-being outcomes for one area with narrow wealth gaps where the difference between the richest and poorest isn't too much versus an area where there's wide wealth gaps where the difference between the richest and the poorest is great. What they found across the board was the greater the wealth gap, the worse the outcome. This is an example of the risk for dropping out of high school, taking each state in the country. And they found a fairly linear correlation between the gap in wealth and the risk for dropping out of high school. Found other things where they looked at countries like the U.S., which almost is always at the far right because it has the highest wealth gap compared to any other developed country, and other countries around the world that are developed, and finds for every other kind of health measure, including the UNICEF's Index of Child Well-Being, the greater the wealth gap, the worse the health outcome across the board. And the other thing that they make a point of in this study is that it doesn't matter how much you make. Your own wealth actually doesn't matter except for if you're in the top 1 or 2%. Even if you are fairly well off, if you live in a community, in a society, in a place where there's a great wealth gap, your health goes down. Place and the situation around you matters almost more than your own personal attributes. Martin Luther King said all of this much better than any of the data or my ramblings ever could. So I'll just read what he said when he got his Nobel Peace Prize back in 1964. In the final analysis, the risk cannot ignore the poor because both rich and poor are tied in a single garment of destiny. He understood that all of these lives were interrelated, and the agony of the poor diminishes the rich, just as the salvation of the poor enlarges the rich. So I get back to that grandmother and those kids with hypertension, and I keep asking myself, what is it that allows a 10-year-old boy to have primary hypertension so early in his life? And I started to think about these issues around stress and the constant trickling of stress. And you start to understand these days how much stress responses are really helpful when big deals are coming up in your life and you really need a lot of adrenaline to help you deal with something, and how harmful they are, how erosive they are when you have a little tiny trickle of stress going through your body every single day. How they affect every single function in your body, including your ability to regulate your blood pressure even at a young age. This kind of stuff is really well understood now, thanks to folks like Jennifer Middlebrooks and Jack Shankoff, and really understanding how the lifespan is affected by the stressors that are placed on a person even when they are a young child, or possibly even in a preconception manner, even before a child is born. Jack Shankoff has put his work into really understanding these ideas of adverse childhood events, early childhood adversity, and you probably start to hear more and more about ACEs in your studies, right? ACEs, toxic stress, and how those affect, in a stepwise fashion, your ability to regulate your emotions and behavior, your ability to adopt healthier risk practices, and eventually your risk for diseases and early death. And there in that pyramid is the reason that a person on Mercer Island can look across the water to Renton and see somebody who's going to live 10 years less than they. These issues of early childhood stresses have factors that affect the kinds of hormone balance and receptor activity that occurs in the brain, the kind of cell function that occur in your immune system, and your ability to respond to behavioral stresses, to angry situations, to difficult challenges from a mental health standpoint, and lead to the kinds of problems that affect you across the lifespan. But I think about all of these things, and I think about that grandmother, and I think about those kids with high blood pressure. And one thing that I always realize working in this clinic now for 14 or 15 years is for all of that data, all of that stuff about place, and about high risks, and about early death, and about abuse, and lack of resources, what I see when they come through the door are these amazing kids with this strong sense of a positive attitude, with this great kind of resilience, with this energy. It's really, it's inspiring. You have to spend time at a place like the Odessa Brown Clinic because it makes you feel younger, it makes you feel more able to take on the world, and it's because of these families that you serve. It's just amazing families. And in the last year or so, I've gotten halfway smart enough to ask these families, what is it about you that gives you this resilience? Because I kind of would say that most of you in this room would not last a week living the lives that these families lead. So not just why is this such a problem, but what is the strength that you have that helps you get through this? And I could spend another hour, and I won't, about what these parents teach me about resilience. It's been really interesting. It's really helped us rearrange some of the programs that we develop and how we do things, how we try to avoid situations that force people into failure, like, oh, if you miss an appointment, then we won't reschedule you again. Little things like that. But there are bigger things about how we try to offer 6 or 8 or 12 different options for someone to succeed or get through a process rather than just one. Because these really resilient moms teach me that they have to be navigators. They have to be able to have many different options or ways to get something done. They can't just have one, because too many times in their lives that one pathway just doesn't stay open on them. It's really fascinating. So we develop programs that have a lot more to do with life needs than they are with healthcare needs. We do a lot of the things that are able to sort of take care of immediate and basic needs. We have a basic needs fund now. We sometimes pay money to help pay a bill when it's really threatening putting a child with a ventilator or with asthma out on the street or something like that. We use money, sadly, sometimes last time we spent a few $100s to pay for a funeral for a child who was chronically ill, whose parents were really poor and couldn't afford it. But it's other basic things, helping to make sure a child has what they need to get to school. A winter coats program right now that makes sure kids have boots and gloves and coats in the wintertime in order to stay warm. Those basic needs, and really interesting and different kinds of partnerships. We've had dental and mental health and medical services in our clinic for much longer than it was ever cool. We were doing that back in the late 70s, early 70s. And it was innovative back then. It was a very new idea to pull those kinds of medical service lines together into one place, to integrate them. And we thought about other ways to integrate different kinds of services. We have something called a medical legal partnership, where we have a lawyer who comes to our clinic and does way more doctoring than I ever get to do, because often when a kid is dealing with asthma, they're living in housing that is actually making their asthma worse. When a child with special health care needs is trying to get to school, there's a battle with the school bus or with the school system about what their legal rights are for an education. And it's this guy, Scott Crane, you should have like a big ass on his chest. He's just an amazing person. He really breaks down the barriers and makes sure that kids get the kinds of services that they need and deserve. It's those programs, those innovations, those ideas like this class where you get a chance to sit with people who are in different professions and share ideas and learn about things and try new things out in your world that really are the innovative moments that allow you to solve some of these big problems that should be easier to solve but aren't. These are the kinds of things that we learn about across the country. A couple of years ago in the New Yorker magazine, there was a story about a poverty clinic, I hate that name, but a poverty clinic that is being run by this amazing Dr. Nadine Burke in San Francisco that really spends most of its time doing what I just talked about, addressing the social determinants of health on a much more aggressive stage than they are working on things like asthma medications or some of the more straightforward parts of healthcare, and really making a difference in their community. When we think about programs based on what we've learned from other experiences around the country, from listening to parents and their resilience, and from seeing what we see epidemiologically across our county, we think about how we develop programs that have a lot of components that we cherish, like they think about promoting partnerships, unusual partnerships especially. They use evidence-based practices. They use early investments in people, training and technical expertise, but also have culturally reinforcing messages and rooted in compassion, delivered with humility, and promoting trust. Trust is one of the most important attributes that we have in our clinic, and if we lose that trust, if somebody even comes to the clinic on our behalf and does not convey that trust to the families that we serve, that's devastating because that harms us forever. Trust is one of the most important things that we can develop. And we have to think about how to be rooted in cultures as cultures become more and more diverse. This is just percent change in diversity across King County, just to show that Seattle hasn't maybe changed all that much in 10 years, but many of the areas in South King County have increased in diversity by up to 300%. And then we have to think about culturally reinforcing messages and support services, not just in terms of race and ethnicity, but across the broad range of what we say defines diversity. The importance of cultural humility, and the importance of understanding that in our healthcare field, we have our own culture, our weird culture, where people wear blue uniforms, and where people have language that has big, long words that ends in itis or osis, that we value things that are kind of esoteric to other people, like I don't know, p-values or relative risk odds ratio numbers. We have this whole nomenclature, and we have this whole thing about who's cool, who's a superior officer in our ranks, and who's a peon. We have this whole system that's very, very different. It could be a culture and a language unto itself. And so we have to think about that when we bring people into our culture to provide healthcare, dental care, and mental health services to them. We have to think about how much power we have in the room, at the dental chair, in the therapy room, how inordinately powerful you are when you're providing healthcare services to people. You have to be conscious of that and remember that. You have to think about when it's important to really be part of the system and really help support that system and be a worker bee to make it better. And when it's important to lovingly revolt, to stand up and really speak powerfully for change. You have to think about what's the difference between thinking about things from an equality standpoint where everybody gets one box and still leaves some people unable to take advantage of something, versus equity sometimes where there's an unequal distribution of resources in order to get to an equal distribution of opportunity. Equity versus equality. We have to think about those things in the way we deliver healthcare. We have to think about the things you'll be learning about in some of your classes around cultural competence, and especially around cultural humility and what that means. How much humility is important in healthcare these days because it promotes openness, appreciation, and flexibility. And most importantly to me, it helps you reattach yourself to something that you try to hold on to as you learn all of these specific, highly detailed and highly complicated information that's going to make you good providers. But holding on to your ability to listen and be present in the moment when you're with a family who needs your care so much. I'll end on this one last slide, which just talks about homelessness for another second. It just says, even if you weren't as much of a bleeding heart as I obviously am in my work, and even if you just cared about financial issues, the cost of putting some supportive housing programs together and serving people in a supportive housing system as opposed to allowing people to remain homeless is a significantly bad way to waste money if your society cares about being efficient with resources. I will stop there and answer any questions you have, because I know some people have to run to get back to the rest of your day. But thank you for listening so carefully, especially after eating lunch. I know that can make you a little bit dry in the head, so appreciate your time.